All right, welcome everyone to the neurology lecture series. We have been doing a combined neurology and medicine lecture for 3 to 4 lectures a year for the last probably 5 or 6 years now. And we're honored to have Dr. Rizwan Kalani give a talk today on lipids and stroke. A little bit about Dr. Kalani. He did his medical school at the University of Florida, his residency at Northwestern University in Chicago, and then came here for a stroke fellowship, then did a research fellowship, a Fogarty research fellowship in India before coming back here and doing another research fellowship currently through the Stroke Net. And so we're honored to have him give us a talk today.
So I'm going to talk about lipids and cerebrovascular disease. Going to briefly go over a little bit of lipoprotein biochemistry, also review some of the epidemiology about of lipids and stroke, and go over some of the studies on lipid lowering therapy in ischemic stroke in particular. And after that, I'll talk about some of the data on emerging lipid biomarkers, including apolipoproteins B and A1. And at the end, I'll mention some of the unanswered questions about the relationship between lipids and stroke. So lipids constitute about 70% of the dry weight of plasma. About half of lipids are sterols, such as cholesterol, and the remaining components include phospholipids, triglycerides, and fatty acids. Lipids have multiple biological roles. They serve as the building blocks for cellular membranes. They function in energy storage and the production of bile salts. And several lipid-derived molecules are important in, they serve as important hormones and intracellular secondary messengers. Because lipids are water insoluble, they're transported from the intestinal system to sites where they're utilized through the plasma in the form of lipoproteins. And so these particles contain cholesterol, triglycerides, phospholipids, apoproteins, and also fat-soluble vitamins. The hydrophobic cholesterol esters and triglycerides make up the core of lipoproteins, and apoproteins and phospholipids, which have both hydrophobic and hydrophilic components, make up the outer core and allow them to be these particles to be soluble in plasma. Lipoproteins vary in size, in density, and also in the lipid apoprotein content. They're classified according to density. Triglyceride-rich chylomicrons, chylomicron remnants, and very low density lipoprotein are less dense than serum, and cholesterol-rich low density lipoprotein and high density lipoprotein are more dense than serum. In the fasting state, plasma or serum shouldn't contain chylomicrons or chylomicron remnants, and this allows us to measure the other lipoproteins in serum. And so LDL cholesterol actually turns out it's usually reported in the lipid profile. The LDL cholesterol that is usually reported in the lipid profile is generally calculated using the Friedewald equation, which is shown here. This formula is more accurate in the fasting state because in non-fasting patients, postprandial chylomicrons can actually contribute to total cholesterol levels and make the measurement less accurate. Additionally, this method is actually inaccurate in when triglyceride levels are greater than 400 milligrams per deciliter, and so that's something to keep in mind. And it also has a higher error margin when the LDL cholesterol is actually less than 70 milligrams per deciliter. Generally speaking, the apoproteins that make up lipoproteins really have 4 principal roles. They're involved in the assembly and secretion of lipoproteins. They make up the structural integrity of lipoproteins. They coactivate or inhibit enzymes involved in lipid metabolism. and they bind or dock specific receptors or proteins that allow the cellular uptake of the entire particle or selective uptake of a lipid component. One or more apoproteins is present on each lipoprotein, and some apoproteins turn out to be sort of integrally linked to that lipoprotein, but others are actually bound to the surface and are able to transfer to other lipoproteins in the serum. There are multiple classes and subclasses of apoproteins. Some of them are actually implicated in neurodegenerative and cerebrovascular disease, but the function of several is actually not very well understood. Each type of lipoprotein particle is associated with a distinct set of apoproteins, and I'm going to talk about ApoA1 and B100 here and a little later in the talk because of the implications in cardiovascular disease and stroke. ApoA1 turns out to make up about 70% of HDL protein. It's a small protein that's synthesized in the liver and in the intestine, and it activates an enzyme called lecithin cholesterol acyltransferase, which forms cholesterol esters and enables the efflux of cholesterol from peripheral tissues. It also has additional anti-inflammatory and antioxidant properties. Clinically, ApoA1 is a marker of HDL concentration. ApoB, apolipoprotein B, exists in two common variants, ApoB100 and ApoB48. The ApoB100 protein controls the metabolism of LDL. It binds to the LDL receptor on peripheral tissues and mediates the endocytosis of the particle. ApoB100 is a relatively large protein. It's synthesized in the liver. There's actually only one molecule of ApoB per lipoprotein particle. And so the measurement of ApoB in plasma is actually a good marker of the sum of VLDL, LDL, and chylomicron remnants. When you look at the epidemiology of lipids in cerebrovascular disease, it turns out that it's a little complicated. The principal risk factor for stroke is, for both ischemic and hemorrhagic stroke, is hypertension. You can see it from the figure here on the left. Hypertension is a powerful contributor to stroke risk in both sexes, at all ages, including in people over the age of 75. And multiple epidemiologic studies have shown the incidence of stroke increases with increasing blood pressure levels. This, however, does not seem to be the case with hyperlipidemia. Even though hyperlipidemia is associated with coronary heart disease, there's a less consistent and significantly weaker association with stroke. It turns out actually that the relationship between dyslipidemia and cerebral ischemic stroke is different than that with intracerebral hemorrhage. Most, but not all, observational studies have shown an association between higher total and LDL cholesterol levels and an increased risk of ischemic stroke. What's shown on the right here is data from the Women's Health Study, which is a large population cohort study of healthy women. And they showed that an elevated total cholesterol of more than 250 milligrams per deciliter was associated with a nearly 2.5-fold increased risk of ischemic stroke compared to a total cholesterol of less than 180. An LDL of more than 130 was associated with a 2-fold higher risk of ischemic stroke compared to a total cholesterol, compared to an LDL less than 100 or so. In the Asia Pacific Cohort Studies collaboration, which includes actually more than 350,000 people, there was a 25% increase in ischemic stroke rates for every 25%, for every approximately 40 milligrams per deciliter increase in total cholesterol. When you look at other epidemiologic studies, though, like the atherosclerosis risk and community study, they've actually shown a very weak and non-significant association between LDL cholesterol and stroke risk. The reasons for the inconsistency between studies is not completely clear, but it's likely confounded by the types of ischemic stroke that are included in the analysis, and I'll explain what I mean by that a little later. Interestingly, when you look at a lot of these observational studies, most have actually found an association between a lower total cholesterol and LDL levels and an increased risk of intracerebral hemorrhage. So in the multiple risk factor intervention trial, there was a threefold higher risk of fatal intracerebral hemorrhage in patients who had a total cholesterol of less than 160 compared to those who had higher total cholesterol levels. A meta-analysis of 23 studies showed an inverse dose-response association between total cholesterol and the risk of intracerebral hemorrhage. The table on the bottom here is from a pooled cohort analysis of the atherosclerosis risk in communities and cardiovascular health studies. And they demonstrated that a low LDL cholesterol was associated with incident intracerebral hemorrhage in that pooled analysis. And so overall, it seems like epidemiologic studies suggest a competing stroke risk with regards to total cholesterol in the general population. Higher total cholesterol seems to be associated with a higher risk of ischemic stroke, whereas lower levels seem to be associated with a higher risk of intracerebral hemorrhage. Again, the reasons for this association and the underlying mechanisms are not very clear. When you look at HDL cholesterol, some, but again, not all, epidemiologic studies find an inverse relationship between HDL cholesterol and ischemic stroke risk. In the Northern Manhattan study that included a multi-ethnic community, higher HDL cholesterol was associated with a reduced risk of ischemic stroke. Interestingly, in the cardiovascular health study data, high HDL cholesterol seemed to be associated with a reduced risk of ischemic stroke in men, but not in women. And there's actually a systematic review that included 5 prospective cohort studies, from which I'm showing a figure here on the right. And they showed a reduced risk of ischemic stroke from anywhere from 10 to 15% for every 10 milligram per deciliter increase in HDL cholesterol. So just like with total cholesterol and LDL cholesterol, some of the results have been mixed, and it turns out that there's really no clear demonstrated benefit of HDL increasing medical therapy on stroke risk. Probably the most inconsistent data is with triglycerides. Epidemiological studies that have looked at the relationship between triglycerides and ischemic stroke are extremely inconsistent, and this may at least partly be due to the fact that some studies have used fasting levels, whereas others have used non-fasting levels of triglycerides. In 2 prospective cohort studies, the Copenhagen City Heart Study and the Women's Health Study, after multivariate adjustment, higher non-fasting serum triglycerides were associated with ischemic stroke risk, but that was not found to be the case with fasting serum triglycerides. So similar to total cholesterol, also similar to total cholesterol and LDL cholesterol, studies have also shown that triglyceride levels are inversely associated with intracerebral hemorrhage risk. So some of the discrepant results amongst the observational studies of lipids and stroke risk may be explained by the differential association amongst ischemic stroke subtypes. So for both clinical and research purposes, neurology, we subtype ischemic strokes based on the likely etiologic mechanism into 5 main categories. And those are sort of displayed here on the right. Atherosclerotic large vessel disease of the major intra or extracranial vasculature is one category. Small vessel disease of the small penetrating arteries supplying deep parts of the brain, which we often call lacunar stroke, is a second category. And there's cardioembolism and stroke from other determined causes like hypercoagulable states or dissection. And then there's this sort of heterogeneous cryptogenic category where we really can't identify a high risk etiologic mechanism for the infarct. There seems to be, from the data that's out there, there seems to be a stronger association between lipids and stroke secondary to large artery atherosclerosis. A few case control studies have demonstrated an association between total cholesterol and LDL with lacunar stroke, but other studies have actually not shown a clear association between dyslipidemia and lacunar stroke. And the relationship there may actually be a lot more complicated. It may be influenced by other factors and vary between populations. And with regards to cardioembolism, even though, again, dyslipidemia is a risk factor for coronary heart disease, most studies have showed no association between dyslipidemia and cardioembolic stroke. Multiple cohort studies, including the cardiovascular health study, the Northern Manhattan stroke study, have consistently shown an association between cholesterol levels and carotid artery atherosclerosis. One interesting study that was done is from the MESA cohort, where they took subjects who had the highest carotid intimal media thickness by ultrasound, and they obtained high resolution cerebrovascular MR imaging, where you can actually visualize the fibrous cap and lipid core of these carotid plaques. And they showed that in patients who had thickened carotid walls, plasma total cholesterol, but not other established coronary heart disease risk factors, seemed to be strongly associated with the lipid core presence on these high resolution MR images. So despite the weak epidemiological evidence that links cholesterol and stroke, one of the strongest indicators that cholesterol has an important role in atherosclerotic stroke comes from the effectiveness of statin therapy in reducing carotid atherosclerotic plaque and reducing the incidence of stroke. There are a variety of lipid-lowering therapies available, and the ones that have been around a while are shown here in the figure and table here. Each have a different mechanism of action, and you can see the differential effect on HDL, LDL, and triglycerides among the different classes of drugs. Statins seem to have the most robust LDL lowering effect, and niacin and fibrates seem to have a more significant HDL increasing effect. The most robust data on lipid lowering therapy in primary and secondary stroke prevention turns out to be with statins. Other agents really seem to have a much less of an established role. In primary stroke prevention trials, several statins have actually been associated with reductions in the risk of stroke, ranging from anywhere from 11 to 40%, depending on the study you read. The top figure here is from the heart protection study, which randomized more than 20,000 patients ages 40 to 80 that had a high risk of vascular disease to receive either simvastatin 40 milligrams or placebo, and they showed a 25% reduction in the risk of stroke in the statin treatment arm. More aggressive treatment has been associated with a further reduction in risk. The bottom figures here from the Treating to New Targets study, and it shows that compared to atorvastatin 10 milligrams, atorva 80 daily was actually associated with a 25% reduction in stroke risk, and that seemed to correlate with reductions in LDL. The figure here on the left is from a meta-analysis of lipid therapy and stroke that showed that with each approximately 40 milligram per deciliter reduction in LDL cholesterol, there was about a 15 to 20% relative risk reduction in ischemic stroke. So, in terms of primary prevention, at least, the 2013 American College of Cardiology and American Heart Association guidelines have made recommendations for initiating statin therapy for people with and without atherosclerotic cardiovascular disease. But according to these guidelines, statin therapy really is recommended for primary prevention to patients who, one, have an LDL of greater than 190. For diabetics who are between the ages of 40 and 75 that have an LDL of greater than 70, and for non-diabetics who have an LDL greater than 70 and also a 10-year atherosclerotic cardiovascular disease risk of more than 7.5% based on pooled cohort equations. High risk, high intensity statin therapy is recommended for people under the age of 75 who are at low risk for statin complications, for people who have an LDL greater than 190, and for diabetics who have a 10-year cardiovascular disease risk of more than 7.5%. Moderate intensity statin therapy is really recommended for other groups. With regards to secondary stroke prevention, the SPARKLE trial was the first clinical trial of statins to be specifically designed to study patients who experienced a stroke or TIA. These were mostly ischemic strokes, but about 2% of the population included here had a prior intracerebral hemorrhage. The study recruited patients that had no evidence of coronary artery disease 1 to 6 months after an index presumed atherosclerotic stroke or TIA, and there were about 4,700 patients who were enrolled, who were randomly assigned to either receive atorvastatin 80 milligrams daily or placebo, and were followed over a median follow-up of about 5 years. And an important thing to point out actually about is that patients who were enrolled were actually enrolled almost 3 months on average after their index event and their index stroke or TIA. The mean LDL cholesterol was 130s in both arms of the trial at the time of enrollment, and statin treatment was associated with 38% reduction in LDL cholesterol. In the treatment arm, it went from an average of 132 down to about 73. And that was sort of compared to a 7% reduction in the placebo group. And what they ended up finding was that atorvastatin 80 milligrams was associated with a 16% relative risk reduction in recurrent total stroke risk. It was only about a 2% absolute risk reduction. You can see about 13.1% in the placebo group and 11.2% in the statin group. So that corresponds to a number needed to treat of about 50. So overall, the effect is pretty modest. The 5-year absolute risk reduction in the risk of major cardiovascular events was about 3.5% in this trial. They actually did a post hoc analysis of this, and a post hoc analysis actually suggested that the benefits of statins on risk reduction were actually similar across the subtypes of the index stroke, and so implying that really all ischemic stroke patients that were included in this trial seemed to benefit from statin therapy. The trial did have several limitations. So, like I alluded to a little earlier, patients were randomized anywhere from 1 to 6 months after stroke, and that's really the period of time after a stroke where the risk of recurrence seems to fall the greatest, especially in patients with large artery atherosclerosis, where statins presumably have the most significant benefit. Ongoing trials are actually addressing the role of statins given immediately after a stroke, not only to help reduce lipid levels and prevent recurrent stroke, but because of implicated pleiotropic effects, some people have hypothesized that they may actually ameliorate cerebral injury related to the stroke itself. The beneficial effects of statins on ischemic stroke is most likely related to their ability to reduce progression or induce regression of atherosclerosis. There was a meta-analysis of statin trials that found that greater magnitude of LDL reduction seemed to correlate inversely with stroke incidence. There may be additional beneficial pleiotropic effects of statins, that are mediated through mechanisms other than their action on cholesterol metabolism. Other mechanisms that have been implicated include inhibition of the inflammatory cascade, antioxidant effects, upregulation of nitric oxide synthase, with which is thought to increase cerebral blood flow, plaque stabilization, and also modulation of coagulation and platelet function. So although evidence, again, suggests an inverse relationship between lipids and intracerebral hemorrhage, the association actually between statin use and intracerebral hemorrhage is extremely unclear. The heart protection study, which was really an old study, was actually the first clinical trial to show a non-significant increase in the risk of intracerebral hemorrhage with simvastatin over placebo. The increased risk seemed to be very small, but in the Sparkle trial, and that's what's shown here on the left, there was a hint of this as well, which showed that patients in the atorvastatin arm were actually more likely to have intracerebral hemorrhage than those receiving placebo. The magnitude, again, of the risk is pretty small, 2.3% compared to 1.4% after 5 years. But and turns out that this has sort of muddied the water a bit, but a bigger sort of subsequent meta-analysis that included 31 trials actually didn't show an increase in the risk of intracerebral hemorrhage with statin use. And that's what this figure here is from. And so the potential increase in risk is likely to be low, given the combination of all this data. Regardless, what exactly we should be doing with patients on statins in the setting of acute or prior intracerebral hemorrhage is controversial. And there are a bunch of different opinions that are published out there in the literature. All the data is pretty limited because it all sort of comes from small numbers, and it comes from post hoc exploratory or observational analyses. The etiology of intracerebral hemorrhage may actually play a role on the risk that statins confer. And the location of intracerebral hemorrhage, particularly in older people, often suggests the underlying pathophysiology. So lobar intracerebral hemorrhage in older folks suggests cerebral amyloid angiopathy, whereas hypertensive vascular disease is primarily responsible for deep intracerebral hemorrhage. And the risk of recurrent deep intracerebral hemorrhage can be reduced substantially by antihypertensive therapy. However, for cerebral amyloid angiopathy, there's really no clear established preventive treatment, and there's actually a much higher risk of intracerebral hemorrhage recurrence. There was an interesting mathematical decision analysis that was done that showed actually for lobar intracerebral hemorrhage in particular, statin therapy is actually predicted to significantly increase the probability of recurrent hemorrhage substantially, and that increased risk actually seems to offset any cardiovascular benefit for both primary and secondary cardiovascular disease prevention in that patient population. There was also another interesting retrospective study that found that statin use in patients who had intracerebral hemorrhage was independently associated with microbleeds that are in the lobar in a lobar distribution on MRI, which is frequently seen in patients with cerebral amyloid angiopathy. And so in this report, they actually showed that statin use conferred a fourfold higher odds of these lobar microhemorrhages being present. And so I think more data is probably needed to understand this a little bit better. Like I mentioned a little bit before, the benefit of non-statin lipid lowering therapies for primary or secondary stroke prevention is not as well established as it is for statin therapies. Although niacin increases HDL levels, a meta-analysis of 11 studies that included almost 10,000 people showed no clear association between the use of niacin and the risk of stroke. fibrates can also be used to lower triglycerides and increase HDL cholesterol. But again, another meta-analysis of, I think it was 18 trials, and again, a large group of patients that were included amongst all those trials, again, provided no evidence that fibrates reduce the risk of stroke. On the left here is actually a summary figure from a meta-analysis that included nearly 80 trials of lipid-lowering therapies, including fibrates and other treatments. And they showed no significant stroke risk reduction of non-statin lipid-lowering therapies. In 2015, there was a trial involving ezetimibe, which inhibits intestinal absorption of cholesterol. That's worth mentioning. And a table is shown here from that paper on the right here. This was a large trial that assessed the addition of ezetimibe 10 milligrams daily to simvastatin 40 daily among patients who had an acute coronary syndrome. And they showed that the addition of ezetimibe resulted in incremental LDL reduction and improved cardiovascular outcomes. You can see that they actually showed a significant reduction here in the risk of ischemic stroke in the arm that got the combination treatment. PCSK9 inhibitors. So PCSK9 is a hepatic protease that actually degrades hepatic LDL receptors, and it leads to an increased serum LDL cholesterol levels. And monoclonal antibody inhibitors of PCSK9 have been developed as relatively new lipid-lowering agents, and they've shown to reduce LDL cholesterol levels in the serum when they're added to statin therapy quite substantially, about 60 to 70%. There were two trials published in the New England Journal of Medicine in 2015, and figures from one of these trials called the Osler trial is shown here, which studied one of these monoclonal antibodies. And the primary endpoint in this was actually LDL reduction, but they did a post hoc analysis of these studies, and they found that they reduced the total major cardiovascular event rate. Over the short period of follow-up, the risk of stroke was very, very low. And there was no significant difference in stroke risk between the treatment and control groups in these trials. And trials that are intended to provide a definitive assessment of cardiovascular benefit of these agents are actually ongoing, so the results should be pretty interesting. Interestingly enough, also in these two trials, they actually showed that there were more neurocognitive deficits reported in the PCSK9 inhibitor use arm. So as studies come out, that'll be something to sort of keep an eye on. Current professional society guidelines, at least from the American Stroke and American Heart Association, are summarized here with regards to dyslipidemia treatment in stroke patients. So they recommend statin therapy with intensive lipid-lowering effects for patients who have ischemic stroke or TIA that's presumed to be atherosclerotic in origin. The guidelines also do recommend treatment for patients with stroke that have LDL levels less than 100, likely, reflecting the fact, which is a change from prior guidelines, and likely reflects both the recognition that patients with stroke have a higher risk of future cardiovascular events, and that statin therapy should be based on overall risk rather than only lipid levels. With regards to intracerebral hemorrhage, the Stroke Association, Heart Association guidelines on management of spontaneous ICH also suggest, because of the literature sort of being all over the place, they also suggest that there's really insufficient data to recommend restrictions of statin use in ICH intracerebral hemorrhage patients. What I wanted to touch on before sort of stopping was just some of these emerging serologic biomarkers lipid biomarkers. They may turn out to provide more insight into the relationship between lipids and cerebrovascular disease. Some work has been done looking at apoproteins, looking at enzymes involved in lipid metabolism and lipid subfractions. I'll briefly talk about just some of this work that's been done on ApoB and A1, lipoprotein little a, lipoprotein associated phospholipase A2, and subfractions of HDL. But given that there's so many lipid species and that their metabolism is pretty complicated, it may turn out that panels of markers or evaluation of this on a systems or a network level may turn out to be a lot more substantive than looking at individual lipid biomarkers, individual lipid components. And because the large-scale study of lipid components and lipid metabolites is now possible with analytical chemistry techniques like mass spectrometry, people are, I think, started calling this lipidomics. So there was a prospective cohort study from Sweden that evaluated different lipoprotein components and their association with ischemic and hemorrhagic stroke by age and gender. And they found that an elevated ApoB and a reduced ApoA1 was associated with an increased risk of first stroke. Interestingly, lower ApoA1 levels were associated with hemorrhage in females, but not in males. The ApoB to A1 ratio, which you can sort of think of as analogous to as an LDL to HDL ratio, was actually shown to have a more direct relationship with the risk of ischemic stroke, even after adjusting for demographics and vascular risk factors in this study. Elevated ApoB and an elevated ApoB to A1 ratio has also been demonstrated to be predictive of ischemic stroke in patients that have had a prior TIA. The inner stroke study, which was showed something interesting with regards to ApoB and A1. This was a international case control study of first ever ischemic or hemorrhagic stroke from 32 countries, and they showed that an elevated ApoB to A1 ratio was associated with a higher odds of ischemic stroke, but not intracerebral hemorrhage. You can see the odds ratio. Sorry, this doesn't really project very well. The odds ratio is 2.2 for ischemic stroke. The population attributable risk for an elevated ApoB to A1 ratio was about 34% in the study. What's I think probably most interesting though is what's shown here on the bottom, that they found significant regional variation in this relationship, with an elevated ApoB to A1 ratio conferring a much higher odds of ischemic stroke and, interestingly, also intracerebral hemorrhage in Southeast Asia. There was an interesting study from East Asia, just to follow up on this, that also found an elevated ApoB to A1 ratio being an independent predictor of intracranial location of atherosclerosis. So this probably warrants further work, because we actually think that intracranial atherosclerotic disease is the most common subtype of ischemic stroke worldwide. Lipoprotein little a is a type of low-density lipoprotein, where a large protein, apo little a, which is shown here, is actually bound to ApoB. Apo little a has a domain that actually is very structurally similar to plasminogen, and as a result, it actually interferes with fibrinolysis by competing with plasminogen binding to molecules in cells, and so this impairs plasminogen activation, generation of plasmin, and fibrinolysis. It also binds to macrophages and promotes foam cell formation and the deposition of cholesterol and atherosclerotic plaques. And there's been a little bit of work on this in stroke. Studies that have actually looked at the relationship between lipoprotein little a and the risk of ischemic stroke seem to have some mixed results. like everything else, it seems like. Um, Studies that assess this in the relationship in Caucasian and European populations actually didn't demonstrate an association with stroke risk, but in the atherosclerosis risk in communities cohort study, an elevated lipoprotein little a level of greater than 30 milligrams per deciliter at baseline, did turn out to be associated with an increased risk of ischemic stroke. The tables here on the right are actually from a report from the Northern Manhattan Stroke Study, where they actually showed that an elevated level of greater than 30 at baseline was actually associated with an increased risk of ischemic stroke as well. And what's interesting, I think, was that this association really was more pronounced amongst men and African American populations in this cohort. So the effects of lipoprotein little a and other lipid biomarkers may actually depend on race, ethnicity, and other factors, and it seems like a lot more work is probably needed. Lipoprotein-associated phospholipase A2 is an enzyme that's expressed by white cells that's involved in the metabolism of LDL to pro-inflammatory mediators. It's a vascular-specific inflammatory biomarker. It's highly expressed in the necrotic core of atherosclerotic plaque, and it's linked to plaque inflammation and instability. The figure on the left here is from a meta-analysis of more than 30 studies that found elevations in lipoprotein phospholipase A2 mass and activity was actually associated with an increased risk of ischemic stroke even after adjusting for other predictors of vascular risk. A report from the Northern Manhattan Stroke Study also found that the association between lipoprotein phospholipase A2 levels and stroke seems to vary by race and ethnicity. The table on the right here is from a trial evaluating the role of dual antiplatelet therapy in TIA and minor stroke that was done out of China. And they actually measured lipoprotein phospholipase A2 activity in a subset of trial participants. And they found that higher levels were actually associated with an increased short-term risk of recurrent vascular events in this population. And then lastly, really HDL subfractions. So because of studies of the association between HDL cholesterol and stroke have yielded mixed results. And there's no clear benefit of HDL increasing medications that have been shown on ischemic stroke risk. Some people have suggested the relationship between HDL cholesterol and cerebrovascular disease may actually be a function of HDL cholesterol subfractions rather than total HDL cholesterol. And so HDL really has two main subfractions. There's a larger and less dense HDL2 and a smaller and denser HDL3. And these subfractions actually differ in biological activity, in biochemical properties, and in vascular metabolism. Some more data from the Northern Manhattan Stroke Study actually found that HDL2 was inversely associated with carotid intimal medial thickness, and HDL3 was actually not associated. And interestingly, the effect of HDL2 cholesterol was especially pronounced amongst diabetics. Another report actually from the MESA cohort found that a higher concentration of these larger HDL particles was associated with a lower risk of stroke, particularly in African American populations. And so this is probably another candidate biomarker that warrants further evaluation. So really to summarize, the key points I think are that lipids have a complicated relationship with cerebrovascular disease. There's a direct relationship between cholesterol levels and ischemic stroke, and particularly atherosclerotic stroke. And the associations seem to be strongest for total cholesterol and LDL cholesterol. There seems to be an increased risk of intracerebral hemorrhage at low cholesterol levels. And statins are really the lipid-lowering therapies that seem to reduce the risk of recurrent stroke in patients who have hyperlipidemia. The available evidence for lipid lowering by other means really the evidence for a significant impact on secondary stroke prevention really isn't there. And so future work probably should include the assessment of novel lipid-lowering therapies on primary and secondary stroke prevention. I think there are a lot of interesting unanswered questions about lipid biomarkers, including various apoproteins, their relationship with stroke, particularly atherosclerotic stroke. Further work, I think, is also needed to understand some of the differences in stroke risk conferred by dyslipidemia in different populations. And given the growing evidence that vascular disease and cognitive impairment seem to share many risk factors, the relationship between dyslipidemia, lipid biomarkers, and lipid-lowering therapies with cognition probably also deserves more work. So I think that's all I have. So if there are any other questions, if there are any questions.
There's lipid lowering and then there's lipid lowering. We end up needing people who are frail and have comorbidities and have LDL 12 and 30. Do the people, I don't know if you said, do the people who have hemorrhages have any correlation with extremely low over-treatment such that you're damaging, causing cell damage?
So the question was, with extremely low LDL levels. Yeah, so I think that, again, the question is really about LDL lowering in patients who have low LDL cholesterol, particularly in older patients. I think I'm not sure there are any answers here. I mean, yes, the lipid, the new treatment guidelines suggest not really targeting LDL, but just using high intensity or moderate intensity lipid lowering therapy with statins. With regards to what exactly to do with patients with LDLs that are really low, I don't think it's completely clear yet. Patients that actually have low LDL that seem to still have high vascular risk is probably a smaller proportion of the population, but it's not entirely clear what to do with those patients. In those who've had an intracerebral hemorrhage, I think I'd worry about them being on lipid-lowering agents, so statins in particular, particularly if they have evidence that may suggest that they have underlying cerebral amyloid angiopathy. And so I think in that population in particular, it may be worth avoiding statins in general, but I think there are a lot of unanswered questions here. I'm not sure I have an answer to that. Sorry.
Thanks for the next talk. Just a general question. I was wondering if there were any genetic factors in particular that predispose people to high fraction of one of the HDLs
So the question is, are there any genetic factors that seem to affect lipids and really anything I talked about? So there's a lot of an increasing amount of genetic work done. I didn't really touch on it here. Nothing clear cut at the moment. Just like stroke is a complex phenotype. It results from different pathophysiologies, and so the genetics work thus far, at least, hasn't really yielded so much. There is, I know, a lot of ongoing work, but nothing substantial that really, I think, can make clinical decision making any easier at the moment.
Just the issue of recurrent stroke and some of the things you talked about, and how much they're ready for prime time. I imagine they haven't really studied randomized trials, but if someone's having recurrent stroke, checking lipoprotein, adding to their stat, these things that I imagine are not quite recommended by guidelines yet.
Yeah, so the question that Sandeep has is there a role for evaluating some of these other lipid markers like lipoprotein little a, apoproteins, for example? Currently, the guidelines actually say that there's no clear role at the moment, mainly because of the paucity of data, and what exactly to do about different levels is not really clear. But I think it deserves more work. I think especially given how sort of different the literature seems to be with heart disease, like in the cardiology literature, ApoB and A1 are actually, that ratio is much more predictive of incident MI than traditional lipids. A lot of work just I don't think has been done yet in stroke. And I think people have sort of generalized stroke, it seems like, as opposed to looking at the different pathologies that lead to stroke. That I think confounds the picture here. But it seems like it's worth investigating, and it seems like it may actually have implications. And I think what's probably most interesting is why there's some pretty large differences between different populations. Yeah, so the follow-up question was, is there a role for adding some of these other lipid-lowering therapies in addition to statins? Is there any recommendation been made in the guidelines? The guidelines have not. At least the 2014 secondary stroke prevention guidelines from the American Stroke and Heart Association have not. They sort of mention it in the body of the text, but I think probably more data is needed. I mean, if you look at that ezetimibe and simvastatin trial, they did show a more substantial risk reduction when ezetimibe was added to simvastatin, but it was really in a ACS population, and how generalizable that is to other stroke patients, I don't think is really clear yet.